Hello, this is Robert Farrow, LPC Supervisor here in the state of Texas, and this is Welcome to Supervision. I am really enjoying this topic because I have a lot of background experience, not only working in multiple hospitals, but working in crisis intervention on the streets of Houston and Harris County in Texas. Being safe on your location is very important, and that's what we're talking about today. This session and this supervision is for primarily my LPC associates that I'm working with and helping get them ready to move into their full licensing. If you are one of them, welcome. I probably have asked you to watch this, and I probably emailed you the link, and we've talked about this one. This is to go in excess of what we've already discussed. I really want you two guys to be safe and to gather this information. If you are not one of my associates, then by all means, welcome. Enjoy. Hopefully there will be something here you can get and glean from the information. It is intended to be helpful. I've said this in a few other sessions that I've talked about. I am not monetizing this. I am not getting any money from it. The whole point of this is to share information, share experience, and thereby make counselors better. Hopefully this is working. I know for me, putting these together, it's forcing me to look at my experience and bringing it together at one point in time so I can share it. Having said that, let me go back into the topic. We are looking at session safety and the aggressive client. You really can't see it in that image there, but it's the aggressive client. Trust me, that it says so right there, right down there. Actually, right over there, right there. Okay, so having said that, let me jump into what we're going into. We're going to be looking at some key points on this today. They include angry versus aggressive versus violent clients. What's the difference? There's a big difference. Emotions and behaviors, baseline differences there. One is going to be the emotional feeling, one is going to be behavioral outbursting. Personal safety, big component. That's really the focus of this one. What led me to do this video in this time period was one of my associates had informed me of how they ran into a problem at a hospital, and a tech, one of the nursing staff, was attacked inside the inpatient psychiatric facility, and that can happen. I want to talk about that a little bit today. We're going to be looking at clothing, room positioning and escape routes, recognizable weapons, and also I want to talk briefly about not being fooled by appearances. Also, looking at group safety. This is kind of an important aspect, not only in your inpatient settings, but in your day treatment, PHP, IOP, as well as private practice group settings. I know for me, I have a group room right across the hall from where I'm sitting in another room, and group safety is very important. As a part of that, we're going to be talking about milieu management as well as milieu therapy, what it is and what it really means as far as an inpatient setting. Because most associates are working in inpatient environments. I know that I've got a few that are not, and I am encouraging you to get that experience, get the exposure, as we've already discussed, to a clinical population group. That way you can actually see and hear and get a sense of what hard, strong, difficult client caseloads can be like when they are actively delusional, actively psychotic, hallucinating, etc. Okay, so what exactly is the angry versus an aggressive client? What makes the real difference here? Well, these are commonly confused. Just because one is angry doesn't mean they're aggressive. And just because one is aggressive doesn't always mean that they're angry. So it can be very confusing. Hopefully, over the course of some time, it'll begin to make sense. So anger, first of all, is the emotion. It is what they're feeling. It is sometimes, well, oftentimes viewed by many people as an unacceptable or a bad emotion. I think the tricky part is recognizing and helping them to learn that anger is just an emotion. It's neither good or bad. We're all going to experience it. It's what we do with it. Do we allow it to change our behaviors, or do we allow it to help us express and begin to have the ability to set healthy boundaries? That's a totally other topic. I'll cover that at another time. Okay, anger as an emotion is oftentimes caused by disappointment, frustration, and in a hospital setting or even outside. Let's say you're working with a crisis unit, or you're going to door to houses with, maybe you're alone, maybe you're with law enforcement, maybe you're working alongside CPS or EMS. There can also be experienced a lack of feeling of control. If your client is feeling that lack of control because there's authority figures present, be it CPS, APS, be it law enforcement, be it already inside the hospital and you got nursing staff, the feeling of out of control and loss of control, it can be so strong of an emotional response that they do get angry and they can become aggressive. Okay, if you've already had classes on this, great. You're already exposed to some of it. If you're working in an inpatient setting, you should have already had a required class, and we're going to talk about those in a moment. Okay, what is the aggression? Well, the aggression is the behavioral side of the emotion. It's the subsequent follow-up, possibly. Doesn't always have to go that direction. Aggression can be intended to cause harm or pain. Does not mean that we're talking about physical harm or pain. It can be emotional harm or pain. There is verbal as well as physical. Name calling, for example, that is a primary verbal aggression. I know that there was a joke years ago when I first got into counseling that if I wasn't being told what to do with myself at least once a week, I may not be doing my job at the inpatient level. As I got more experience, I realized that's not always the case. My job was not to push buttons, but to help the client identify their buttons and then learn how to deal with those buttons. Physical aggression, on the other hand, is where the verbal goes into the next level. Okay, think of it as a stair-step kind of approach. You're going from one layer to the next layer to the next, each one increasing its intensity, increasing its potential for harm and, dare I say, violence. We're going to talk about violence in a moment too. Okay, so what are some of the types of aggression? Well, there's a couple actually. There's instrumental aggression. Now this one is kind of unique in the sense that it is objective, it is focused, it is difficult to deal with. I jumped ahead on this one. What we're looking at here is the responsive aggression. This one is a hostility-based focused aggression as opposed to objective. Okay, I know that sounds a little confusing right now, but give me a moment and we'll work this one out. We're going to go into a little more detail on each of these two types. Okay, now I will say this: some of the research I have read indicates a third type, but that research was based on child psychology as opposed to adult, and it was also in Asia, the research that I found. And so in the school systems, I'm not entirely certain at this point or comfortable in going into that third one for this video, because I'm not sure it would translate well into a mental hospital psychiatric environment. So in any case, we've got two basic types of aggression: instrumental and responsive. Let's go into more detail on them. So the instrumental, it's also known as a cognitive aggression. Well, as you already know, you know what that word means. It's a thought out aggression. There's some contemplation involved. So this one is, the objective is focused and they've constructed the aggression. It is intentional. It has this quality of being thought out, planned. A good word that you would use would be what's called mens rea. It's a legal term. If anyone has watched Legally Blonde, that word is used in it, and it's used quite interestingly by the young attorney. In any case, in this setting, the aggression is thought out, it is planned, it is calculated, it is intentional. There is a goal to it. There has a preferred outcome. The person using aggression has it planned. They expect it to respond in a certain way to get certain needs met. The intent is to harm another person. It's not always essentially objective, but it can be a consequence, okay? So that would make more sense with looking at it from the viewpoint that the use of a coercive technique, a planned, for example, in the movie Mean Girls, there's some qualities to some of those girls where they're definitely demonstrating a thought out, intentional way of striking at someone verbally. It doesn't have to be physical. It is very much a head game tactic. This one is uniquely, it is learned, and it's learned through vicarious reinforcement, just picked up over time from childhood, observing in a family where there's domestic violence, where there's coercion, where there is do it my way or else mentality. They will learn this. People can pick this up. It is probably one of the easier forms, I think. This is just a personal opinion, but I think it's one of those easier qualities that kids can pick up on. It is a maladaptive coping strategy. If I can't get my needs met by asking, well, then I can get my needs met by coercion and by manipulation. Here's where it's kind of interesting, though. It is also associated with a callous and unemotional trait, such as those that are seen as lacking guilt or empathy. It's commonly perceived in the realm of a criminal element, and I will go in to say that as looking at guilt and empathy, guilt, sympathy, empathy, those emotional conditions require a good bit of understanding, and this is not the environment I want to go into those with everybody. But I will say this: there are motivating factors that determine the strength of empathy. And that's what I'm doing my dissertation on for my doctorate. So with regards to how it applies to the cognitive aggression, it can be intentionally used, and it would appear to be lacking that empathy quality, but it's actually strategic. Okay, responsive aggression. This one here is actually just the way it sounds. It is responding to an event. So this is a hostile aggressive type. It's in response to a perceived threat or insult. This one here can be culturally motivated, but it is also usually, at least I think, here again my opinion, a quality of recognizing when an individual oversteps a boundary. Okay, so let me clarify that. Working with adolescents and teenagers, if you are not aware of how they speak, their vernacular, their use of wording, you can come across as aggressive to them when you may not realize that. I've also worked with individuals working the streets as a crisis interventionist where their perception of threat and a slight or an insult can be very jarring when we don't realize that that's what they're perceiving it as. It really is something that is learned in the environmental aspects. So it is a response. So the response of aggression is a reaction. It is often unplanned. It is impulsive, fueled by the intense emotions, and it's a little different than the desire to achieve a goal. Now, I believe here again, this one here is going to be a much more common one that you'll find in inpatient settings. The aggressor typically has a sense of loss of control during that outburst. They also are experiencing heightened physiological arousal. Okay. Here again, let's talk for a moment about neurological aspects of the sympathetic and the parasympathetic systems, and how the nervous system goes into the fight or flight reaction. Emotionally, they're there. They are in that condition. So when you're dealing with them on an inpatient level, recognize they're ready to rock. Okay? So we're going to talk more about this in a moment, but the responsive aggression is that angry, outbursting kind where if we catch it, we can help de-escalate it. But I think this is the one you're going to run into more often than the cognitive, planned out type. Okay? Like I said, it's more common. Okay, aggression and violence. Now guys, this one here is kind of unique. It's a little confusing as well. Violence is aggression, pure and simple. Acts of violence are aggressive. This is not a passive thing. This is an active, aggressive intent to cause harm, pain, death, destruction. This kind of aggression is very much what we see in the news. It is what we see in the school shootings, what we see in terrorism. It is intentional. It is violent. Now, it can be, in some cases, just an emotional reaction that becomes violent, but all violence is aggression. Now, not all aggression is violent. Okay, I'm going to have a list here in a moment of the different kinds of non-violent aggression. Okay, so aggression does not have to be physical. It can be just more emotional, verbal. It can be very interesting to see it unfold. So here's a list. Gossiping, spreading rumors. Here again, back to that movie Mean Girls. Criticizing others behind their back. Again, more of the Mean Girls. Bullying. Guys, this one has been in the news repeatedly with regards to the school shootings that have been going on for the last 20 years. This is an aspect of aggression that leads to violence in other individuals. Okay, so here's one of the big caveat problems. Which one came first, the bullying or the violence? I personally believe it's the bullying that comes before the violence. Bullying is a form of aggression. It does not have to be physical. It can be just verbal and emotional. Ostracizing people. You cut someone out and they don't feel that they deserve to be cut out. That can be extremely aggressive. Turning people against each other. There again, very aggressive. Dismissing the opinion of somebody. Just blowing them off. That can be observed as being or perceived as being aggression. Interestingly enough, stealing a boyfriend or a girlfriend, that can be pretty aggressive. They may not view it as aggression. It may be viewed as under the auspices of love, but to the one receiving the loss, that would be an aggressive move. Threatening to break up with a partner if they do not comply to your wishes. This is straight on coercion. This is manipulation, and it can be very aggressive. It does not have to be violent. There is a difference. Flirting with another person to make a partner jealous. Other than being childish and juvenile, junior high level, this is aggressive. So there's a list of aggressions that are not violent, okay? So an interesting little caveat there. Some other examples that I read about was one of playing football, rugby, or something where they're going to be aggressive. It's competition, it's sport, but at the same time, it's not intended to be violent. For example, judo, not intended to be violent. It is a sport. It is also a self-defense technique. There is aggression in it, but that's just the way it is. Okay, that's an aspect of that art form. All right, so let's go into personal safety now. We've looked at some of the separations there of anger, emotion, aggression, the types of aggression, and then some aspects of violence. We're going to come back to some of that as we go through this. But personal safety, this here is really going to be more of my personal experiences that I want to share with regards to what will help you to stay safe in your personal aspects of counseling, be it you with a group, be it you with an individual, or with a family, if you're inpatient, if you're at home, or if you're in a day treatment environment. So let's look at clothing. First thing you want to look at is, what are you wearing? Okay, is your clothing, you'll notice I never have a tie on. In every video, I never have a tie on. I do have my set of keys that I keep pinned to my shirt, and that's just out of simplicity and ease. Could this be used as a weapon on me? Sure it could. I know where it is, and I know how that would be used. But clothing-wise, is your clothing extremely loose? Is it extremely tight? Is it appropriate to wear? Are you wearing something that allows you to move freely? Okay, I would highly discourage the use of, I think what's called the pencil dress or a pencil skirt, where they're extremely form-fitting. It prevents you from being able to move physically. Okay, now if you're wearing a looser piece of clothing, then it wouldn't be so much of a problem. Also, take into account, if things do get physical, clothing will be grabbed. It can be ripped. It can be torn right off of you. I have seen it done many times. Your clothing is, for work, you want to look appropriate, you want to look professional, but at the same time, don't have such an attachment to it that if it gets ripped up, that you'll really worry about it. Okay? Just a little heads up on that one. Okay, room positioning and escape routes. Guys, I cannot stress this one enough. When you're going into a hospital environment, the way you enter a room, the way you exit a room, the way the room is positioned, where you sit, where you stand, very, very important. Okay, so let's look for a second at a group room. Your average group room has one door in, one door out. It may or may not have windows. It will likely always have chairs. There may even be a desk in the room. Always have your escape route. Have your ability to hit that door and not look back. Okay? If things are going down and you need to exit that room and get help, then you do it. Okay? Not all hospitals have group rooms with safety buzzers that brings attention to it. Okay? I've worked in environments in the past where that didn't exist. All right? Now, the room positioning is also important, having your back to the door, having yourself an escape route, but also recognizing that if you're doing an individual session, not just in a group session, let's say you have an individual, still you have to maintain that safety. Your position in relationship to them and where they're at, very important. The ability to have a chair that rolls if you're going to sit down, very important. You may need to be able to just do something as simple as backing up. Just push away, and it can be very, very helpful. Okay. Now, weapons. In an inpatient setting, weapons are a lot harder for them to obtain, but trust me, they can get them. As simple as a leftover paperclip can be turned into a weapon. Something as simple as those little golf pencils, that's a weapon. a sharpened down toothbrush, because most all those hospitals give out a small package of items, a comb, a toothbrush, those kinds of things. Trust me, these kids and these adults have all seen movies. They know how to make this stuff. They can turn it into whatever they need to turn it into. It can be easily obtained. I know on the adult units, the adults will be allowed to shave, but at the same time, that razor blade has to be returned to the tech. The tech is supposed to check the blade to make sure that it's still in the razor. Sometimes they miss it. So you got to be on the lookout for possible weapons that are out there. Now that's inpatient setting. What if they're doing day treatment? They're coming in for PHP and IOP. Well, you have less of a chance of knowing what's on their person. Many hospitals now have a metal detector that they have to walk through, but that doesn't mean they're not carrying something. There's a lot of metals out there that make very sharp items that are not detectable. Okay, just got to be aware of that. If you're going into their home, if you're working in a crisis unit where you're going into people's homes and you're mobile, it doesn't matter if you're with someone or not. A home is loaded with weapons all over the place. And I ain't talking about guns. I'm talking about things like a hammer, things like the old-fashioned heavy stapler, a pair of decent scissors, a paring knife, real small, but guess what? That can mess your world up so fast you have no idea, okay? Amongst weapons, I've had training in this one, if you have someone who is less than 10 feet away, a knife is more deadly than a gun if they're that close to you. It's just that simple. Space is everything. Recognizing that if you're entering into their home and you're going to do counseling, you're in their world, they know where everything is, you don't. Be aware of that. Be aware that in counseling, your safety is your responsibility, nobody else's, okay? Recognizing the weapons that are out there. Also, don't be fooled by appearances. Just because you've got someone who is old or elderly, geriatric, does not mean they cannot mess you up. I will share a couple experiences of this personally that I went through, and I can laugh about them now. But way back years and years ago, I was a paramedic, and I took my eyes off of a senior citizen. He was in his late 70s, and when I came back around, he had a fist there waiting for me, and he pushed me. It knocked me for a loop. I saw some stars. Didn't knock me out, but it sure hurt. And it was my own fault because I had him in the back of the ambulance, and he looked away. I moved away, and when I came back into his line of sight, he forgot I was there and didn't know who I was. As far as he was concerned, I was kidnapping him. Okay, another one. Working at a psychiatric hospital, had a patient in a wheelchair. Was told by the nursing staff that he was wheelchair bound and was just an addict. Okay, so for any of you who know anything about working with addiction, that is one of the few areas where confrontation is common, and the techniques I had been taught early on was slightly more confrontational than what I would use now. And I called him out on some of the things he was saying. Now, mind you, this is during the initial intake session on the unit, doing his biopsychosocial. Well, he came out of that wheelchair and attacked me because I insulted him. As it turns out, not only did he not need a wheelchair, but he was dual diagnosed with a comorbid diagnosis of schizophrenia as well as multiple substances. So don't be fooled by the appearance. Just because they're in the wheelchair doesn't mean anything. Just because they're old doesn't mean anything. Last story. I got picked up by an 8-year-old little girl when she wandered off of the unit. Okay, now granted I was a lot younger then and a lot thinner then, but still she was 8 and I was about 24. and she lifted me up off the ground just by about a foot because she wanted off the unit. Now, she was not very big. Top of her head came to my chest, okay? And so, but she was able to grab me by the waist and lift me up. Could I have gotten hurt? Yes. Could she have gotten hurt? Definitely. Was that aggression? Oh yeah. Was it angry? Yes, she was. Was it violent? Definitely. Okay. Don't let the size, the age, or the condition of your client make you assume anything. You can get hurt. Okay, let's talk about group safety for a moment. Group safety is a little bit different. You still want to maintain your personal safety as well as your room positioning. In a group environment, room position is very important. Okay, so milieu, fancy term here. For those of you that are working inpatient, you have probably heard it. If not, all I can say is you should have heard it. It should have been discussed. Milieu is French, meaning the social environment. It is a form of management, and it is a type of therapy at the same time. Milieu management is really the responsibility of the nursing staff. The tech and the RN on that unit, their job is to be in tune with what's happening on the unit. How are the clients, the residents, the patients responding to each other? Is somebody getting angry? Is someone getting worked up? Are they feeling a loss of control? Your nursing staff is supposed to be Johnny on the spot with these items. Now, how does that apply to you as a counselor? If you're walking through the unit and you see or hear something that seems aggressive, it seems angry, emotionally, it doesn't have to proceed to the level of violence, but if you catch it, you need to respond to it. You need to react. That is a part of the milieu management. If you see two people getting ready to get into it, intervene, separate them, get help, move them in the room apart from each other. That way that you can talk to one or the other, whichever one you get, and find out, hey, what's going on? You look a little upset. Are you upset? What's happening? That technique I used right there is one that's taught in just about every form of de-escalation. Just asking questions. Okay, the therapeutic aspect of it is that in theory, we're helping them learn better ways of existing in a social environment, in a society. The smaller group area gives us more management to contain the problems. Containment. This is the real element here. It's containment and reduction of aggression and violence. You're going to run into that, okay, on a psychiatric facility unit, especially a PICU, where they're all coming in, they're actively hallucinating, actively delusional. They may be still on substances from the street or from home. Your job and the job of the nursing staff is to contain and reduce that emotional aggression and potential for violence. Okay, how is this done? Well, it's done through the use of some seclusion rooms, rooms that are set aside for basically locking people up until they can calm down. It's what I would call the adult level of a timeout. Can a client request to go in a seclusion room? Definitely. I've seen it happen many, many times, especially because the seclusion room is quiet. It's relaxed. It has no furniture. It has a mattress on the floor, or there's bedding, or there's materials there to make it soft and comfortable. The walls are padded. This room is commonly done in movies. Not all of the movies are accurate to reality, but even in the movies, they show a seclusion room environment. De-escalation techniques. I mentioned using one a moment ago. PMAV, Prevention and Management of Aggressive Behavior, CPI, SAMA. These are commonly used techniques. CPI and SAMA are trademarked. They're newer. PMAB has been around forever and a day. Honestly, this is just my opinion, they're all very similar. They teach very similar things. Some of their theory behind it may be different. For example, Sama has a theory that parallels that of Aikido, whereas CPI has more of a cognitive-based approach. And PMAB, back in the day, back in the 20, 30 years ago, was really more of the hands-on approach of de-escalation. Okay, now there's also chemical restraints. If you take people into, let's say you're going into the emergency room, one of the first things like Bentab or one of the other emergency-based psych facilities they'll prescribe a medication to help calm the client down, depending on how severely aggressive and or violent the client may be. Ativan, commonly used. Thorazine, not as used as much, but it's still available. That one is stout. That one puts people on their butt and they'll sleep solid for a good amount of time. Hands-on, physical restraints. Guys, this one is your option of last resort. Any of the de-escalation techniques that I mentioned, they all are going to say the same thing. When you went hands-on, that is only because the verbal de-escalation techniques were not effective and the client escalated and you had to do it for personal safety of the client, the group, the milieu, the environment, and yourself. Like I said, it is the last level. You don't want to have to go to this if you don't have to. Separating them, giving them space, doing what you can to help them regain that sense of safety and control to reduce the nervous system's output, that fight or flight response. It takes practice, okay? And this is not something that can be done just, right away. The more practice you have, the better you get at it. I have seen some psych techs that frankly were better at doing de-escalation techniques than many counselors and social workers, simply because that's all they did. 8-hour shift, 5-6 days a week, they were de-escalation experts, okay? If you find one, watch them, talk to them, observe how they do it, especially if they're good at it, because you can really learn a lot from how they're doing it, because that's all they do. All right, interesting quote. I think it's real important that I share this one with you guys. Creating a therapeutic milieu is a basic intervention in mental health nursing practice and is inclusive of everything in the immediate inpatient environment. Everything in the milieu is meant to promote healing and include the staff, the physical structure of the unit, the emotional climate of the staff, and patients on the unit. I got this straight out of one of the nursing magazines for mental health. Guys, milieu management and therapy is huge. Group safety, when you're in the group and you're leading a group, that milieu is then handed to you as being a part of your responsibility. You can coordinate with the nursing staff, and I would highly encourage that, but it is still your responsibility at that moment in time. For that hour of your group, for that 60 minutes, it's yours. Okay. Now I'm going to really date myself in age. This comes from a TV show that was out in the late 70s, early 80s called Hill Street Blues. And there was a character, the desk sergeant, who would always do their roll call. And at the end of every roll call, which was usually the beginning of the show, he would always say, hey, remember, let's be careful out there. And it's exactly what I'm telling you guys. That's why I'm using this image, because safety is everything, not just for your client, but for you. You cannot help them to be safe unless you can help provide them a safe place to be in, to reacquaint themselves and their nervous system with how to be safe, how to bring down the nervous system, how to bring down the heart rate, how to be calm, how to convey their emotions without becoming aggressive. You got to be careful out there, guys. There's a lot involved that happens here. All right, so a brief list of references. Honestly, there is so much information on anger, aggression, and violence. The world of psychology, counseling, psychiatry is flooded with this research. There's so much out there. This is not even a drop in the bucket. This is just such a small amount that is out there on what can be discussed. Seriously, go to Google, type in Google Scholar, and then look up anger, aggression, and violence. I think you'll be amazed with what you'll find. So, okay, quick review. We have looked at some aspects of anger, the emotional component. We've looked at aspects of aggression, which is either going to be instrumental. They've thought about it, they've contemplated it, they have put action then into the aggressive part of it. It doesn't always have to be physical. It can be just verbal. It can be just emotional. And then there is the reactionary kind, where it's just purely emotional. There's no planning involved. They're just reacting to the feeling of being insulted or the feeling of loss of control. They're important qualities to recognize, okay? The reactionary one, much easier to de-escalate and manage. If they've thought it out and they've planned it, it's a manipulation that you may not be able to de-escalate because they're doing it intentionally. The mens rea is strong, and because of that, they have put through scenario breaks in their mind of, okay, if I do this, what'll happen? That one's much harder to work with, okay? It's important for you to be able to recognize those. So, welcome to Supervision. Guys, this one was a very brief discussion of the aggressive client, the angry, and what you can do with it. Recognizing your safety is important. This one topic is one that you can take, I don't know how many hours. I would say hundreds of hours of class time, lectures, and educational credit classes on how to manage these issues. The research on it is immense. So, as I mentioned a little bit ago, stay safe out there. Keep doing what you're doing. Keep learning from the mistakes. You're going to have them. Hopefully they won't lead to any kind of major injuries. For those of you that are my associate, if you have any questions, talk to me the next time we're in our face-to-face session. Send me an email if you need to. If you're interested in more information, then by all means, we can look into other aspects, okay? But for those of you that are not, I hope you found this video to be educational. I hope you found it to be interesting. I know I've had fun putting the material together and pulling up some of the research. Like I said, there's a lot of it out there. So, in any case, until we meet at our face-to-face session time, you guys be safe, and just think about your environment. Look at that milieu. Listen to it. You know, keep your ear to the ground and your eyes open. You'd be surprised what kind of stuff you may see. Until next time, take care.